how early do you think in a pregnancy a mother should begin seeking prenatal care?
Okay. So the moment the mother realizes she's pregnant, and usually within the prenatal period, or what regularly called the antenatal care, is divided into three. We have the first trimester, which spans from 0 to 13 weeks. The second trimester, from 13 to 26 weeks. Then the third trimester till delivery. So it's best the woman is seen within the first trimester, which is between the 4 weeks to about 13 weeks. And once she realizes she's pregnant, either by missing a period or having done a pregnancy test which is positive, she has to immediately report so that she will be initially assessed to confirm the pregnancy, the site, its location, and if there are any other comorbidities she's already having, then it will be addressed early enough.
Perhaps the reason why maybe some people may not want to visit the hospital so early in their pregnancy is that they do not know what goes on. Say, I'm pregnant, I should go to there's nothing in my tummy yet, nothing has formed yet, why should I go? What does a typical prenatal visit look like?
All right.
What would the doctors do when you get there? What does it look? Is it like a normal hospital visit where you go, they take your temperature, they take your blood pressure, and then what does it look like?
So it comprises that a bit. So once the woman reports, she's welcomed, her particulars are taken, her vital signs are taken, the blood pressure, pulse, respiratory. We also do some preliminary checks. That's the urine. We look at it's a dipstick. You just take a small urine sample. We check for the presence of proteins or glucose within the urine. In the initial visit, a history will be taken, looking out for if this was the first time she's been pregnant, if she has had any deliveries. She will be asked the outcomes of those deliveries. Were there any complication within her antenatal period or during the childbirth or postpartum? And if also any medical conditions she might be having, if she's hypertensive or diabetics. Some of the clients might not know this, so probably their first time at the visit would have been their first time in hospital. As the blood pressure, the sugars are checked, it can be picked up. And some of the booking labs, that's the routine labs a woman takes so that we know the state she is. An example is the blood group. If she's O negative, then we know that's a resource negative mother. So we'll counsel her throughout the pregnancy and intervene where possible, giving the immunoglobulin D, etc. Also, with the booking labs, if we do what we call G6PD, glucose 6-phosphate deficiency. If she has a food defect, it means there are some drugs she can't be given, sulfonamides, and one of the pregnancy medication we give, the SP, sulfadoxine pyrimethamine, to prevent malaria. She will not be a candidate for that, so that will be detected. If the HB electrophoresis is a big word, but that's
what is it?
Yes, so you are looking at the sickling status of the patient.
Okay.
Usually, the sickling status just gives us a positive or a negative, but with the HB electrophoresis, it helps you give you the genotype of it. So we have the AA, we have AC, SS, SC. So if the patient is a sickle cell, we'll note, and we'll have a specialized care and more frequent visits as compared. So after the history is taken, looking out of for all the risk factors, and she will also be examined to look at the abdomen, if any swellings or any, depending on the gestational age she's got into, we correlate how large the uterus is with the age. It helps us know whether the developing fetus is growing appropriately or not, and other factors too. It can help detect fibroids and others, and will be managed thereafter. So I think basically that's what's, and also do an ultrasound to determine the location of the pregnancy.
From what you're saying, there's a lot that happens when women, when they first get pregnant and they visit, they go for prenatal care.
Yeah.
It means there's a lot that goes on, because someone would be there and be like, I just found out I'm pregnant 2 weeks ago, 3 weeks ago. Why should I waste my time to go? They're just going to check if I have my temperature is high and my blood. I know all of that, so I won't go. So if you're listening to me and you're a woman, a lady, you just got pregnant and you are doubting whether you should go for prenatal care or not, this is your sign that it's important. There are a lot of tests that need to be run on you to ensure that you and the baby that you're carrying are healthy. Now, nutrition is a very important part of pregnancy. And what are some of the most important nutrients that a pregnant woman must prioritize?
Okay, so once a woman is pregnant, there's a developing fetus, and she should know that while she's eating, she's not eating for one, she's eating for two. And according to the WHO, positive pregnancy experience for antenatal care, some of the recommended nutrients is we have iron, folic acid, zinc, calcium. These are very essential in the development of the baby and even the mother as well. So she should be eating diets which is rich in iron, taking contomere, ayoyo, and all
the
those
green.
Yes, the
Yeah,
green
the
to
green
get the diet. During
Is
the
dawa
pregnancy,
good?
Yes, dawa is also good. Yeah.
Yeah,
So
because me, dawa, where I come from, we don't joke with dawa. So
then fruits and vegetables, oranges, we get vitamin C from that, which also aids with iron absorption in the body, and also calcium-rich fruits, crabs, and oysters, etc., and also seafoods. With that, they will get iodine from it, because when they have low levels of iodine, the fetus too can suffer what we call cretinism, and also there's mental retardation of the newborn whilst it grows up.
Iron has come up a lot when you were prescribing it. Most of these things have iron. It seems iron is a very critical nutrient that a woman needs during pregnancy. What makes it so important?
All right. So iron is essential in the synthesis of red blood cells and the hemoglobin. I think a lot of the time we hear that, what's your hemoglobin level?
Yeah.
So the hemoglobin is a molecule which carries oxygen throughout your body. So when we breathe in, the oxygen is taken up by this hemoglobin and is sent to the various cells which needs it. So if your hemoglobin level is low, then it means you are not delivering enough oxygen to the tissues in the body. And the placenta, that's the communication between the mother and the baby, and that's where the baby derives its nutrients from. So if your iron levels are low, it means you have a low hemoglobin level, and in effect, the baby is not going to get enough oxygen and nutrients to grow, and the baby will tend to be having a low, small for gestational age. That's what we call it. The baby is too small, can lead to preterm birth. And also with the iron, whilst the woman is pregnant, if her HB level is already low, at time of delivery, she's going to lose blood. After delivery of the baby, there's some amount of blood that should be lost. And this can predispose her to what one of the major causes of maternal mortality in the world, which we call the postpartum hemorrhage. So already her starting level of HB is low.
So when she loses more blood, then
she'll decompensate.
What do you think are some of the major deficiencies pregnant women in Ghana have in terms of nutrition? What are some of the major nutritional deficiencies that, in your experience working in this field, you have come across that it seems a lot of people, a lot of patients that come and who are pregnant usually have these nutritional deficiencies?
Okay, so the most common is the iron deficiency, anemia, and some of the notable causes is one, their nutrition, their poor intake, they are not feeding well, and some due to their socio-economic status. The others too who have a lot of children, multi-parity, so they tend to not have time for themselves. They have a family to take care of, so they don't focus on their diet. There are others too who, because they've had a number of deliveries, they feel they are experienced and they wouldn't even want to embark on the antenatal journey. They know what goes through, so they tend to come very late in the pregnancy. And there are others too. During pregnancy, they have these cravings. They what we call pica. They've been eating clay, shrey, and others. So research found that eating shrey is a symptom of iron deficiency. So most likely they are iron deficient. That's why they have that craving, the urge to be eating those shrey, which we term pica.
Does it have something to do with ice as well? Eating ice, because some pregnant women also crave ice. Do you think it's related to this
for
deficiency in iron?
For the ice as a pica, that's from the research what I got, they wasn't associated. During pregnancy, they sometimes have cravings for a whole lot of things. Some ice cream,
like they want watching by the gutter, and
yes. But with the pica, the shrey, and the rest, when they are iron deficient, they have more cravings for this. And if they don't report for us to notice it and correct it, they continue eating this shrey. And with the shrey, it rather worsens the iron deficiency because it also binds to the iron and prevents its absorption.
So the very reason why you are eating the shrey
is further worsening and creating, so it
there's no way you can win.
A vicious cycle.
Interesting. So with this, so once the iron issue is solved, automatically the cravings will stop?
Yes.
Yes.
Once
they won't feel like eating shrey anymore.
Yes.
Incredible. Because I've seen a lot of pregnant women who would crave.
And we discourage them against that because it also further prevents iron absorption.
Right. Now, according to some stats that I have here, Ghana's maternal mortality rate for 2020 was 263.00. That's a 7.79% increase from 2019. So between 2019 to 2020, there was a 7.79% increase. Why do you think in the 21st century, in 2024, Kwame Nkrumah's Ghana, as a colleague of mine would say, in Kwame Nkrumah's Ghana, women are still dying when they go to deliver? Why?
Okay, so with the issue of maternal mortality, which is death of a woman whilst she's pregnant, or 42 days after childbirth, irrespective of the site of the pregnancy and the duration of the pregnancy. It's found out that one of the primary aim by the WHO to prevent this is to prevent unintended pregnancy. So if the woman is not pregnant in the first place, there wouldn't be any maternal mortality to talk of, or infant mortality. So why I raise this point is the need to prevent unintended pregnancies, which also have their burden too. And in doing this, we have contraception, which helps to prevent pregnancy. And with pregnancy, it should be timed and you should space it as well. So once the education and knowledge, there's a lot of misconception about contraception here and there. There are young women who say they haven't given birth before, so they will not embark on that, but might end up having an unintended pregnancy and could have adverse outcomes. So that is a way to reduce that. Aside that, there's also the lack of skilled attendants. There are areas that lack midwives, gynecologists or doctors, and also there's remote access. And this maternal mortality ratio is the whole of Ghana. So we have to target all the remote areas, their lack of access to health, and also the sociocultural practices and women empowerment could all factor to this. Also, if we break this down, then I think at a point we'll talk about the delays that result in maternal mortality. That's delay in seeking help, and also delay in reaching the facility where offered could be helped. When the client has gotten to the facility, the delay that occurs there as well in initiating the treatment. All right.
So if all things being equal, if a woman is pregnant, does her prenatal screenings and whatever, when it's time for delivery, labor, gets to the hospital on time, encounters a skilled personnel to deliver her, all things being equal, pregnancy should not lead to death. There shouldn't be any risk of death when it comes to pregnancy and delivering.
Yeah, so it's going to reduce the mortality rate. It's going to reduce it significantly.
So if these issues that you're mentioning have all been solved, what else could lead to? Is there something inherently risky about childbirth?
So that's for the normal pregnancy, but there are some pregnancies which are complicated by itself. Either one, the client has a medical condition which could pose a health, which could cause harm to the mother during the antenatal period, childbirth or delivery. And there's also the postpartum. So it doesn't end by the woman delivering. We have to follow them up. I'll give an example. There are some women who are obese, and they have a risk of what we call deep vein thrombosis. They have clots in their they develop clots in their vein. So such clients, we assess them. So after delivery, quite a number of times, maybe we'll do the anticoagulants for about 3 days.
What is anticoagulants?
So
please break it down for the listeners.
Yes, yeah, they prevent blood clots. Anticoagulation. So there are some of these clients that have to continue on even at home. They should be taking the shots of the anticoagulants. So they can have a normal delivery, everything, antenatal, and we say they are deemed fit, but they can report back having difficulty in breathing, chest, and they would have thrown a clot into their lungs, and which we call pulmonary embolism. So it's also related to the.
Talking about complications,
Yes.
there is this case where a woman who is about 6 months pregnant detected severe bleeding during the pregnancy, and doctors say there has been a movement of her placenta, and now the placenta is covering her cervix. How does something like that happen in pregnancy? Did she engage in an activity that shifted, or do these things happen naturally?
Yes. So usually by the 6th month going with the womb, there's a division that comes. It's we call the lower segment of the uterus forms. All right, and usually the placenta has to migrate to the upper part, the upper segment. So that's with the normal pregnancy. But there are instances whereby there's the placenta is impeded from moving. And an example could be if maybe the patient has had a previous scar on the uterus, probably from a previous cesarean delivery or an instrumental delivery or whatsoever. It can also lead for, can prevent the movement or the migration. Other times when there's probably structural let's say like uterine fibroids and other things within. Usually the placenta wants a place which is rich in blood, and with the upper segment of the placenta is vascularized than the lower segment. So we call what the placenta trophotropism, where it moves to where there is blood. But if there is something that is impeding or there is poor blood supply, it can tend to be at the lower segment, covering the cervix. There are other cases whereby the placenta is so large. For example, those who have gestational diabetes, who have twin multiple gestation, that's more than one fetus. So the placenta is going to cover a wide area, then will end up extending into the lower segment. So with this, it's going to cause what we call antepartum hemorrhage. Earlier on, I mentioned postpartum hemorrhage. Yes, that's after delivery. So whilst pregnant, we have the antepartum hemorrhage, and two major causes which we have to address is the placenta previa, which I've just described. That's when your placenta is in the lower segment, within 2 centimeters from the os, either covering it or there are classifications for that. Then we have what we call premature separation of the placenta. The placenta can detach from the uterus. So when it detaches, it's going to bleed, and it's a major obstetric hemorrhage. We call that abruptio placenta. And it can lead to either the fetus dying immediately or can compromise on the fetus. So with this bleed, we have to intervene quickly. So let's imagine this patient, it occurs at a remote village. By the time she will get to a higher center where she can get a cesarean delivery, she would have lost a lot of blood already before that.
Now, Doc, there is this conception that I want you to confirm or debunk. There is this conception that a woman who has had an abortion before is of a higher risk or has a higher risk of developing complications during pregnancy. How true is this? Is there any truth to this at all?
So a woman who had had an abortion before, it depends on what type of abortion she had. Was it a safe abortion or was it an unsafe abortion? And if a safe abortion, she's at less risk of developing a complication thereafter. But if it was an unsafe, maybe the instrument that was used was not sterile, she developed infection after the abortion period. There can be disruption in the uterine lining. So you can have sometimes uterine synecdoche or Asherman's syndrome.
What are you saying? Calm down. What are you saying? What is Asherman? What is...
So the anterior and posterior uterine
let's pretend I know what anterior and posterior is. Hey, I'm listening.
Yes. So when there will be injury to the endometrium, that's the inner lining of the uterus. So in healing, it can get adhered to each other. Then that can result in some complications. And also, depending on the sterility, how the procedure was done, they can also be predisposed to pelvic inflammatory disease if untreated well, and can cause the fallopian tube. That's where after fertilization, it occurs in the fallopian tube, and the fertilized egg moves into the cavity. So if there are disruptions in this, it can inhibit the movement, and the baby would decide, let me just stay at wherever I've gotten to grow. Then you develop an ectopic or zero. But currently we practice the safe abortion care, which is a comprehensive abortion care. And anybody who has had already tried some form of termination medically, she should she should report to the hospital so that she will be assessed to see whether everything is out completely, whether the product is the retained product is out completely or not. Other than that, these can have a toll on a future fertility.
Quickly touch on this for me. Abortion. What's the state of abortion in this country? Is it legal? Can you quickly touch on it?
Yes. So it's legal, and within the legal framework, it gives the circumstances under which it can be carried out. So it should be carried out by a registered health personnel. It should be in a facility which has been also registered and by HEFRA, and the procedure should be a standard procedure as it done, taking into consideration the aseptic technique, making sure there's no infection, and appropriate counseling post the abortion, giving your antibiotics, and also family planning counseling. Yes. So there are instances where the law gives caveat. That's when the pregnancy is going to cause harm to the mother, based on either one, the medical condition the mother has is not safe for her to have it, or even complications from the pregnancy. There's what we call hypertensive disorders in pregnancy. Popularly noted one is the preeclampsia. So she develops blood pressure during the pregnancy, and this sometimes it can be that bad and it's destroying her organs. So with that one, yes, we have to terminate the pregnancy because the only cure is getting the placenta out, ending the pregnancy. It's the pregnancy which is causing that. So it has to be terminated.
All right, listeners, you're still listening to Z in the Morning on Z 101.9 FM. My name is Abdullah Remedy Saka, sitting in for Mr. Jerry Ham, the usual host. And we're speaking to Dr. Philip Edem Agbo. He's a resident of obstetrics and gynecology at the Kolebu Teaching Hospital. We're speaking about maternal health. This is the health and wellness segment of Z in the Morning. Now, Doc, let's talk about the infants. There is also infant mortality. We record some infant mortality cases. in the country. What do you think is the biggest contributor to this particular thing?
All right. So with the infant mortality, looking at the causes, we have the preterm birth, low birth weight, neonatal sepsis infections, and birth asphyxia, and so forth. So out of all the infants, which are those who are under 1 year, majority of this cause of death is from the neonatal period. And neonatal period is the period after delivery till 28 days. So we have the early neonatal and the late neonatal. So out of 4 of every death is from the neonatal causes. So we, in addressing the neonatal causes of death, we address the bigger problem, because that's the using the quality improvement tool. That's where you target. Okay, so
no, go
right.
on.
So in addressing the causes, so it's just as from antenatal period. Once you are getting a healthy baby developing, you are at less risk of prematurity, preterm birth, low birth weight, which has its effects after delivery. And also during delivery, the baby is assessed. We do what is called the ABGA score. Initially, the baby comes out. We assess that in the first and the 5th minute. So it helps us to pick if the baby is in distress, if she has a birth asphyxia, then quickly the pediatrician come in to address that. Those who are premature, there are a lot of problems with them. They can either die from hypothermia, which is low temperature. Because they are born before their time, they are not able to regulate their body temperature. Well, yes, as compared. So they can die from that. They are prone, they are prone to infections as well, and they are prone to infections and dehydration, and they lose a lot of heat, a lot of fluids from their skin quickly. So they are nursed in the neonatal intensive care unit, which we have the NICU. And I think the NICU services is restricted to just a few facilities across the country. Quite a number of district hospitals don't have that services. So the baby will now have to be referred, take a long journey to another facility which has these services.
And there's risk.
Yes.
There's risk between the commutes.
Yes, transporting the baby, because having that right medium to convey the baby across could be a challenge, and that leads to their death.
Breastfeeding. Yeah. How important is breastfeeding when a child is born?
All right. So breastfeeding is essential. During the antenatal period, the baby is feeding from the mother through the placenta. So once the placenta is out, baby is out, baby still has to feed. All right. And this is the time whereby the breast milk during the antenatal period is developing. So immediately after birth, the recommendation is within 1 hour after birth, the baby should be attached to the breast for breastfeeding. And the first few hours, the breast milk that comes out, which we call the colostrum, is very rich in antibiotics. It's very rich in immunoglobulins, which helps the child fight infection and has the adequate nutrients for the baby to grow. It's recommended that the mother exclusively breastfeeds for 6 months After that, they can add the complementary feeds, and this helps to gain weight. The baby will grow well, so you don't have the issues of a low birth weight. A low weight of the baby during the child welfare clinic, and they also encourage mother to child bonding. Yes, as they are attached, they get more bonded to the child as well.
So what you're saying is that inadequate breastfeeding can lead to infant mortality.
Yes. Yeah, they are predisposed to neonatal infections and can die as a result of that.
Right. Let's talk about, you mentioned genotype.
Yeah.
I know it's an issue that a lot of people do not understand.
Okay.
AS, AA, AC, SS. How does this all, what do they mean, basically, in a layman's term? What do they mean, and how do they affect pregnancy and the potential to lead to stuff like maternal mortality or infant mortality? How does it fit into this whole conversation?
All right. So we have also the rhesus compatibility.
Yes, there's the rhesus,
compatibility.
Negative and all of that.
Then we have the sickling status. So with the rhesus compatibility, when you have a mother who is negative, that mother doesn't have antibodies to positives. All right. So sometimes when we have our blood group, someone will say I'm A positive, I'm B positive, O positive, O negative. So that positive or negative, that's the rhesus. And so if the mother there's no issue if the mother is a positive. But if she's a negative, what happens is that when she's pregnant and the baby is positive, the maternal immunoglobulins or her soldiers in her body, they occasionally cross the placenta barrier to the child.
Hey.
Yes. So as she is negative, she doesn't have any antipositive.
Okay.
So in her first pregnancy, the child is okay because the soldiers who are coming don't have the negative. They don't have the positive. They are not antipositive. But anytime within the pregnancy or delivery, whereby part of the baby's blood gets into the maternal circulation, then it means the baby's red blood cells, which are positive, will be detected by the
negative mother's blood.
The security agencies that there's a foreign, there's positive. So the mother will mount an immune response to the positive. So usually the first delivery would have escaped. But subsequent ones, now the mother has developed the anti-positives. So during the pregnancy, they will be crossing the placenta barrier to the child, and they'll start destroying the red blood cells of the child.
Oh.
Yes. So the child is going to have anemia. Like even though it's in the womb, the baby is going to have, the fetus is going to have anemia. So once the baby is delivered, because there have been distractions you'll notice the baby is jaundiced. So early, within 24 hours, if baby is jaundiced, then it's pathological. It means there's a problem. So by subsequent pregnancies, by then the mother has fully developed the antibodies. So they will destroy the baby, and within the womb, the baby has what looks like in adult you call a heart failure. So hydrolysis fetalis. So the baby will even die. So they will start having intrauterine fetal deaths and others. But as I earlier said, history is very important because there are some mothers who are O negative. They wouldn't have had a delivery before, but they might have abortions or terminations in the past.
which had that.
Yeah, which has caused
Caused
her
them
sensitization. So, clients who are O negative, when they have an abortion, you have to give them anti-D. There's a medication we give, anti-D, to counteract all the fetal cells which have come in. Yes. So she might have, by her first delivery, or have a bad outcome. But it's not because like of the abortion. It was because of the exposure. That's good. Have that.
This is very interesting. Now, listeners, you can join the conversation. We are speaking to Dr. Philip Edem Agbo. He is a resident of obstetrics and gynecology at the Kolebu Teaching Hospital. You can join the conversation on 0544321019. Send us a WhatsApp message. You can also send a message via our social media platforms on ZFMGH on Instagram, Facebook, and X. 0544321019. You can join the conversation if you have any questions that you want to ask the doctor. Now, someone has sent me a question here, and she says that, what advice do you have for a woman who is AC, of the AC genotype, going into a pregnancy?
Okay, so a woman who is AC, there's no much known complications. She can safely go through the pregnancy. So the issue is their partner. If the partner is an AS, because those who are AC, when you just do the sickling, it will give you sickling negative, but they are AC. The sickling test alone only detects the presence of the S hemoglobin. All right. Yes. So those who are SC, SS, because of the S, it will be positive. Then you have to go ahead and do the HB electrophoresis. So the issue is that the fetus she could have, there's a probability the fetus could have SC or SC if the partner is a carrier, as in an AS. Yes.
What if the partner is an AC as well?
So if the partner is an AC, then they can get an AA, but CC is not compatible with life.
It doesn't. Wait. What do you mean it's not compatible? It doesn't happen, or?
Yeah. So there will be missed abortion, like the fetus will die.
Okay, so a miscarriage can be caused by the fact that both partners are.
Yeah, there are some of the miscarriages is by chromosomal abnormalities.
Oh, really?
Yes.
This is
there
new.
are some that it starts, then it just.
Wow.
Yes, so it's a natural deletion.
So if both partners are AC, it means that it's either they have a baby with AA or perhaps they'll have a miscarriage.
Either they have a baby with AA or AC.
No, but you said, okay, AC. AA or AC. Yeah, okay. AA or AC. But then CC cannot happen.
Yes.
Interesting. This is very insightful, and I believe that our listeners are learning a lot from this session. Now, let's talk about our healthcare. We have a couple of more minutes to go, I think 4 or so. But let's talk about our healthcare system. Now, what are some of the challenges with our healthcare system, especially with regards to maternal health, and how do you propose that some of these challenges be resolved?
Okay. So the healthcare system that spans from the 3 levels of delay in seeking care. So there should be more health education at the community level, so that the women are able, they first of all know the need to report for prenatal care when they are pregnant, and how to identify the risk factors. If having an unusual bleed, any discharge, or any symptoms, severe headache, their vision being blurred, having vomiting, excessive vomiting, this could all point out to something. So they will promptly report. Also, our road networks, which is the part of the system, areas which have poor road networks, they are bumpy, and it delays access to the health care facilities, and also ambulance services. I think currently we have quite a number, but there is still a challenge. Sometimes some of the clients, they are not able to afford, and the ambulance service will request full support, or yes, there's something they have to pay. Then this can all lead to delay, and there are some areas that all they have is the tricycle, the aboboya, like in some of the roads, and this is what they carry their pregnant women on. There are some areas that they have to cross a river or a water body before they can even reach out. So these clients they need it, but there's accessibility. And also, what now with the health institution itself, the client has now reached the institution. There's also the challenge, which are the health care workers who come into contact with the client. Are they able to make a diagnosis that this bleeding probably is not a heavy issue? It's abruptio bleed. This is a placenta previa bleed, or maybe the client will come brought, she's having a vaginal discharge a lot. You have to differentiate. Is it that her, locally we say, her waters have broken or not? As they've broken earlier before, otherwise they will be misdiagnosed, even though they have reported to the facility. And promptness in initiating treatment. There's the need to triage. So there are a lot of antenatal cases, but you have to segregate who needs prompt attention than the others. Maybe she might have come late, but all hands on deck must be. Or there's a client who has a high BP, her urine proteins very high, and she's symptomatic. We will not just give the antihypertensives, then discharge her home. There are cases whereby they are high risk pregnancies. Maybe the patient has had a previous cesarean session, cesarean delivery, or others, but might be being seen at a CHIPS compound or a health center where they can offer cesarean delivery, and might be seeing her through to deliver, and there can be issues. So even at the level of the institution, they should know the cases that are within our level. Those we have to refer for a higher consult, and that will help reduce the risk. And also blood services. Yes, there's a challenge with blood donation. Now, currently people, they don't have voluntary donate blood. We need blood products so that we can help manage the obstetric hemorrhages. And during the antenatal period, we encourage their partners to donate so that during delivery, our blood stock is there. Because sometimes the patient has come, yes, even but the blood type we want is not there, so we'll not be able to offer, even though we have whatever to take, but there is no blood, so maybe we can't go in or whatsoever.
All right, thank you very much, Dr. Philip Edem Agbo. He is a resident of obstetrics and gynecology at the Kolebu Teaching Hospital. Doc, it has been an insightful conversation. I wish I could keep you longer, because there's so much I would like us to delve in. But you're definitely coming back. Thank you for your time this morning on the show. All right, listeners, It's been another wonderful show. It's about 3 minutes to the top of the hour 10. Yeah, we are a little overrun, but I'm sure the